that now includes insulin resistance and hyperinsulinemia, as well as hyperandrogenism. So if we can't really well define it, how do we treat it? So a little bit of epidemiology. This is the most common hormonal disorder in reproductive age women. So, Dr. Sauer hit the nail on the head here. This is something we see every day, right? Depending on how inclusive our diagnostic criteria are for PCOS, the incidence is anywhere, from 5 to 20%. When you use a more inclusive diagnostic criteria, like the criteria, the Rotterdam criteria, up to 20% of reproductive age women will meet criteria. If you use a more restrictive NIH criteria, it's up to 10%. Most common ovarian disorder causing oligo or amenorrhea, and accounts for up to 70% of anovulatory infertility. So this is a huge and very common issue. So how do we define it, right? So NIH back in 1990 said it has to require both oligo-ovulation and hyperandrogenism, either clinical or biochemical. In 2003, there was a ESHRE-ASRM committee meeting in Rotterdam that said you can actually have 2 out of 3 oligo-ovulation, hyperandrogenism, or polycystic ovaries on ultrasound. And then in 2006, the Androgen Excess Society said that it has to include hyperandrogenism and either oligo-ovulation or polycystic ovarian morphology. The important thing to note is that all of the diagnostic criteria stipulate that you have to exclude other etiologies of irregular menses and hyperandrogenism. So things like congenital adrenal hyperplasia, things like hyperprolactinemia that can cause some of these disorders if you don't rule them up. Like, so someone could meet the diagnostic criteria for PCOS, and if you don't rule these other disorders out, you're sort of misclassifying them and potentially not treating them appropriately. So there have been consensus meetings since the Rotterdam meeting back in 2003. There was a big meeting in 2012, the NIH work group, which essentially affirmed that they recommended using the Rotterdam criteria in research studies, the more inclusive diagnostic criteria, and then a more recent international evidence-based guideline again said that they built on the consensus of Rotterdam. And one of the interesting changes in this most recent meeting is that people are starting to talk about using AMH, which REIs and general OBGYNs use clinically to assess quantity of oocytes within a woman's ovary. Women with PCOS having a high number of follicles, these women have high AMHs. And so for the part of the criteria where polycystic ovarian morphology is used, some are suggesting that elevated AMH levels can be used interchangeably with that ultrasound finding. This was sort of their algorithm for diagnosis. They basically said if you have, and of course, remembering to exclude other causes, if a woman has irregular cycles and clinical hyperandrogenism without another cause, and they're saying what they're using to rule out, you have your diagnosis. If there is no hyperandrogenism, then you're going to test for biochemical hyperandrogenism. If you find it there, you've got your diagnosis. If you still don't have that and you have irregular cycles or hyperandrogenism, then you can go to the ultrasound or the AMH level. An important distinction is that in adolescence, you're not using the polycystic appearing ovaries as a defining criteria for PCOS. You really need to have the irregular cycles and hyperandrogenism to make a diagnosis. You can suspect it, but you really, because they have so many follicles as adolescents, to use the ultrasound criteria is not appropriate. So PCOS is a spectrum of disorders. The most classic phenotypes, people are going to have either A or B. That's up to 2/3 of PCOS patients. That includes ovulatory dysfunction, hyperandrogenism, and polycystic ovarian syndrome. So A will have all 3. B will not have the polycystic appearing ovaries. But that's the bulk. But it's not everybody. There are some people that will ovulate and have semi-regular cycles but still meet diagnostic criteria for PCOS. There are some that don't have the hyperandrogenism. The Androgen Excess Society Committee would say that these don't meet the criteria. The Rotterdam and the most recent international consensus group says that they do meet the criteria. And then there's similar distribution of these less classic phenotypes for PCOS. So when we talk about management, I think it's important, and sort of the theme of this talk is that this is not a one-size-fits-all management. There are different manifestations of the disorder. there are different chief complaints that these patients are coming in to deal with, and management of those specific issues is what we're going to talk about here. So a little bit about the etiology of PCOS, right? It's with a lot of these things, it sort of feels like the chicken and egg situation. You know, there's at the multiple levels of the HPO axis, as well as some peripheral tissue like insulin receptors and adrenal, there's dysfunction. So to say that there's just one problem sort of doesn't do the disorder service. So, one of the reasons I love reproductive endocrinology and just endocrinology in general is it just kind of makes sense. It's top down, right? So at every level of the HPO axis, there's dysfunction. So there's gonadotropic dysfunction, and although it's not part of the diagnostic criteria for PCOS, elevations in LH secretion relative to FSH are commonly seen in women with PCOS. At the level of the ovary, there's follicular arrest, right? So, we're trying to get one of the small follicles from a antral follicle to a periovulatory and ultimately ovulatory follicle, and there's an arrest at that level. Many, but not all, women with PCOS will have insulin resistance and hyperinsulinemia. There's dysfunction of adipose tissue, and certainly we see a lot of hyperandrogenism. And these, at the different levels of the axis, feed back and forward on the other levels to worsen the condition. So when we talk about management, we're going to sort of think about all these different levels of dysfunction and how we can manage symptoms. So like I said, some but not all women with PCOS will present with insulin resistance and elevated insulin levels. This is threefold higher than non-PCOS women, and independent of BMI. So there are lean PCOS patients that still have pretty profound insulin resistance. So, when we're talking about management, some but not all women will have this, and therefore not everybody needs to be managed with insulin sensitizing agents. This high insulin level can, again, everything's going to feed forward and affect other levels of the axis. High insulin levels can worsen some of the symptoms of hyperandrogenism, right? So high insulin levels are going to reduce levels of sex hormone binding globulin. That's going to increase free androgens. Those free androgens are the ones that the patients are going to, be symptomatic from, right? They're going to have coarse hair growth. They're going to have acne. And, these are what they're going to come in complaining of, and we're going to talk about management. There's also a direct stimulatory effect. So it's not just reduction of sex hormone binding globulin. There's a direct stimulatory effect through the IGF-1 receptor, and then sort of an indirect by reducing IGF binding protein 1, which leads to higher IGF-1 levels, which leads to higher androgen production locally in the ovary. So again, multiple levels of the HPO axis and peripheral insulin resistance can worsen some of the manifestations of the disorder. So this is a great review. Nature Reviews 2018 sort of breaks it down nicely. Principles of treatment. So there is no universal treatment. It's symptom oriented. It's lifestyle first, right? So just about every one of the symptoms can be improved, maybe not completely corrected, and we'll talk about that with regards to the ovulatory dysfunction. But lifestyle changes can make a big impact in some of the hormonal abnormalities in PCOS. There's no specific drug currently approved for PCOS, but there are targets, right? So that when we're talking about management, we're going to talk about targeting androgen excess, oligoovulation, and insulin resistance. And, again, it's not one size fits all. The goals of the patient at that stage in her life are going to dictate her treatment, right? So when we're thinking about management, these are just some examples of patients that, that I see sort of clinically. A 22-year-old with irregular menses, acne, and hirsutism, a 32-year-old with morbid obesity and 2 years of secondary amenorrhea, a 33-year-old with morbid obesity and 6 months of infertility, a 39-year-old who successfully conceived and delivered. She's 1 month postpartum, and she had a C-section for a failed induction due to her gestational diabetes. These are all women with PCOS, but how we're going to approach them and treat them is going to vary. So, our endocrine patient who's not trying to get pregnant, right? So this is someone who's coming in, irregular menses, acne, hirsutism. menarche at age 10, cycles every 1 to 3 months. They've had acne worsening since their teens. They've got some hair growth on their chin. Physical exam, they're mildly hypertensive, they're obese, they've got facial acne, they've got some hair growth on their chin. One of the places I always look, this was ingrained in me early in my training, is to look at people's neck. You know, look behind their neck, look where if they wear necklaces in friction areas, to look for skin tags. That's a very almost pathognomonic sign for hyperinsulinemia. You can look for some acanthosis nigricans as well on the posterior neck. So, you know, move the hair out of the way, look at the back of their neck. You can you know, sort of know what their insulin status is by looking there. One of the things on the differential diagnosis, which is rare but something to consider, certainly for residents thinking about taking board exams, is to look for violaceous striae on the abdomen, and worse hypertension. The answer is going to be Cushing's disease. But in clinical practice, we don't see that as commonly. And then, you know, this is a patient that had a polycystic ovarian appearance on their ultrasound. So what labs we're going to do, we're going to, you know, they're coming in with amenorrhea, rule out pregnancy, checking an AMH, which may become part of the diagnostic criteria, looking at androgens, right? So we're gonna rule out congenital adrenal hyperplasia. We're gonna rule out an androgen source, rather an adrenal source of the testosterone production. A testosterone, some might argue a free testosterone is unnecessary if you have a normal testosterone. Check their thyroid, check their prolactin, look for other causes of irregular menses, some sort of screening for insulin resistance, and we're going to talk about options for that. Check their CBC, check their electrolytes, include their transaminases. Up to 40% of women with PCOS will have some component of non-alcoholic steatohepatitis. And, you know, on one of those examples, I think I had someone who had secondary amenorrhea and morbid obesity for 2 years. Until proven otherwise, she's going to have hyperplasia of her endometrium, and you've got to evaluate that. So how do we screen for insulin resistance? You know, in research studies, the euglycemic hyperinsulinemic clamp is the gold standard. No one's doing that clinically. No one, you know, these I included them as just things that you may see in research settings, but really, you know, in some research studies, people are calculating HOMA or quickie as a little bit more quantitative, reproducible in research studies. I think in clinical practice, when you're just sort of looking for it, a 2-hour GTT is probably the gold standard, but that requires them to have multiple sort of touch points to do it. I will confess that we often just do a hemoglobin A1C and a fasting insulin and glucose as a quick and not quite as accurate, but easy one blood draw fasting in the morning, and provides a lot of information to screen for insulin resistance. So depending on what we find on our clinical exam, on the complaints of the patient, we're going to talk about targets for treatment, and we're going to consider, you know, are they complaining of androgen excess? Are they, you know, are they having menstrual irregularities? And do they have either clinical or lab evidence of insulin resistance? So we're going to talk, so androgen excess first. So it's a key feature of PCOS. In some diagnostic criteria, it's critical. There's excess production in the ovaries and to a lesser extent the adrenals. There's also increased free androgen due to the suppression of sex hormone binding globulin by elevated insulin. So what's the mechanism for this? So, you know, we talked about the FSH and LH ratios. Elevated LH stimulation at the level of the ovary is going to just primarily increase androgen production. The hyperinsulinemia, we talked, there's a direct effect on androgen production. It also potentiates the effect of LH, like in the actual ovarian follicle. It also reduces sex hormone binding globulin. So again, multiple levels of different axes within the body are working together in this situation in a bad way to promote androgen excess and the complaints that come along with it. So how are we going to treat it? The mainstay of treatment for somebody who's not trying to conceive is a birth control pill, right? So how does a birth control pill help with hyperandrogenism? Well, it's going to lower the production of androgens, right? It's going to suppress that pituitary LH stimulation of the ovaries and LH-dependent ovarian androgen production. It's also going to increase the estrogen component of the pill is going to increase the production of sex hormone binding globulin. which I always think of as sort of a sponge circulating in the blood to bind the androgen and reduce the free androgen. The pills also have a effect at the level of the adrenals to reduce the production of certain steroidogenic enzymes that produce adrenal androgens. So both at the level of the ovary and at the level of the androgen, birth control pills are going to reduce androgen production, and they're also going to reduce free testosterone via sex hormone binding globulin. There's a lot of talk about which pill to select. All birth control pills are going to reduce androgen activity. The progestin component of certain birth control pill formulations, some are more androgenic than others. So in general, norgestrel and levonorgestrel tend to be a little bit more androgenic. With that said, if a patient has been on it and tolerates it well, they don't necessarily need to change it. If they're on a birth control pill and complaining of hirsutism despite that, you may want to try a different formulation. Sometimes these low estrin or even 20 microgram dose pills are sometimes too low on the estrogen component side. Sometimes a 30 or even a 35 microgram pill will do better. A Junel, which is kind of like a low estrin, or a Sprintec, which is 35 micrograms, are some of the pills that we often use. But really any combined birth control pill will do a good job to reduce androgen activity. Hirsutism. So again, first line is going to be birth control pill, but sometimes that doesn't cut it. So there are other anti-androgen medications available for use in PCOS. Important thing to remember is to always use them in conjunction with the birth control pill if the patient is a candidate for a pill or some other very reliable contraception. If you're taking an anti-androgen medication and you do conceive, especially if it's a male fetus, there can be some genital development abnormalities due to the you're blocking androgen production, and androgen production is trying to form normal genitals, and it can cause some disorders there. I still see many people come in, sometimes some well-meaning dermatologists, less commonly general OBGYNs, that will put someone on spironolactone, and I'm like, oh, so what are you taking for birth control? I'm like, no, I'm not. I'm like, well, did anyone tell you that you should be? Because it really should be second line. When that's not, and typically I'll use spironolactone. Some of these other ones have more risk. In my clinical practice, I don't use them, but they're available, and there's data on using them safely. Cosmetic treatments, obviously shaving, plucking, electrolysis. A lot of patients educate me on the various new cosmetic treatments available. I think, in my experience, laser tends to be the one that works the best for the longest. Once a hair follicle has been sort of, turned into a terminal follicle with that coarse hair production, it's going to keep coming back. So really destroying it at the level of the hair follicle with a laser can have a more lasting effect. So sort of I like these reviews. Again, if anyone, this review in Nature Reviews is a really nice overview on management. They break it down into these algorithms to follow. It's not cookbook medicine, but it is kind of nice to think of it this way. Somebody who's complaining with hyperandrogenism, well, if they're seeking fertility, most of our treatment options are not something that you're going to use. Birth control pill is contraceptive. Anti-androgens have risk, so you're not going to really do much at that point. You could talk about laser to sort of get them through until postpartum, and then you can try to reduce androgen production at that point. If they're not seeking fertility or they're candidate for birth control pills, yes, use the birth control pill. Oh, I'm sorry, did they have a contraindication? So if they're not a candidate, then you can go on. If they have a contraindication, then you're gonna have to do anti-androgens primarily with some other secure contraception form. If they do not have contraindications, then we go down the path of birth control pill first, and then if that doesn't cut it, then adding in an anti-androgen at that point, which is the algorithm that I follow in clinical practice. With regards to irregular cycles, we have to really think about endometrial protection, because these are, I remember from residency on the GYN service, doing hysterectomies on women in their 30s with endometrial cancer. These are the ones that if you're not vigilant, these are the young women that can develop these changes. So again, lifestyle is the mainstay, like the first step, and we'll talk about, you know, the data on that. Birth control pills, if they're candidates, if it's contraindicated, continuous or cyclic progestins. Depo-Provera is an option. I don't love it personally because of the weight gain effect, and often, you know, these patients are obese or at least overweight and don't like that as much. If there is insulin resistance, we were going to talk about treating that with metformin and talk about inositols as well. But you know, if they're a candidate for birth control pill, I know it sounds kind of like a broken record, but the mainstay of treatment for PCOS for somebody who's not desiring pregnancy is a combined OCP. Lifestyle modification, what does the data show? First line, right? So weight loss improves a number of outcomes, regardless of what, you know, what specific diet. I think because a lot of women have insulin resistance and impaired glucose tolerance, a low glycemic index diet makes sense. But regardless of the way that they lose the weight, a lot of the metabolic parameters will improve. It's not just calorie burning with cardio. An increase in lean muscle mass will also improve insulin sensitivity. So that's kind of a 2-for-1. You can, you know, get some of the metabolic effects, but also reduce some of the hyperinsulinemia. Cochrane reviews looked at the, you know, how effective is lifestyle modification of PCOS. Reduced free androgen index, reduced weight, reduced BMI. A little bit back and forth on the effects of glucose tolerance. There's a lot of variability in some of these studies. There hasn't been any class 1 data showing improved fertility or ovulation. So, you know, really when the goal is pregnancy, we may have to intervene pharmacologically as opposed to just lifestyle intervention. What does the data show on the effects of bariatric surgery for PCOS patients? So it's certainly not first line or second line, but there are women with considerable obesity and comorbidities that meet the criteria for bariatric surgery. This is a Human Reproduction Update 2017 meta-analysis looking at a number of studies that have looked at this in both men and women. So although there's not a male PCOS phenotype, there is this male obesity associated secondary hypogonadism, which they looked at improvements in both PCOS symptoms and this MOSH in men. And the data was pretty impressive. So, you know, resolution of PCOS. Now, I don't think everything got better, but I think a lot of the markers that they were using, looking at free androgens and cycle regularity, almost everybody had improvement. Hirsutism in 53% resolved. Menstrual dysfunction improved in almost 100%, 90+% there. And the men showed significant improvement in their male obesity. I have to go back because I can't remember. Male obesity associated secondary hypogonadism. So significant weight loss will make huge differences in this. But again, this is, you know, kind of a drastic move. The recommendation is that they should wait at least a year after surgery to conceive. So, you know, maybe not the 41-year-old with, you know, getting towards the later years of her reproductive window, but, you know, a 28-year-old that wants 4 children and has, you know, 150 pounds to lose may be a candidate for bariatric surgery with pretty impressive results. So now we're going to talk about how we're going to talk about insulin resistance. So metformin. What is metformin? It's a dimethyl biguanide. Back in the early 1900s, they found that these classes of medications had glucose-lowering properties. There's been a number of agents used through the years. Some, I think, were a little bit more potent, and you know, femformin and buformin, they almost worked too well and had a dangerous side effect of lactic acidosis. So those are taken off the market, but metformin has been approved for the use for type 2 diabetes in the US since 1995. It comes from the goat's rue plant. Good trivia item there. How does it work? Still, despite being used for almost 30 years clinically, the exact mechanism of action is a little bit unclear. It works within the mitochondrial electron complex. It inhibits some of the respiratory chain complex 1. It makes AMP kinase more active, and basically it reduces hepatic glucose production, so gluconeogenesis. It reduces glucose uptake from the GI tract. It increases peripheral insulin sensitivity, and it stimulates fat oxidation and reduces fat synthesis and storage. So all good things for someone with metabolic dysfunction and impaired glucose tolerance. It has a a glucose lowering effect in diabetics, but it tends to be glucose neutral in people with normal blood glucose, so you don't have to worry as much about hypoglycemia with women taking metformin that don't meet the diagnostic criteria for type 2 diabetes. And clinically, so what are some of the side effects? I think anyone who's prescribed metformin to patients, biggest, most dangerous side effect we have to worry about is lactic acidosis. Most common side effects, GI, right? So about 20% of patients develop it. That's from studies. I would say clinically it's higher. We slowly will titrate up to the goal dose. I think if you start too fast, people get horrible side effects and stop taking it, which isn't going to work for them. We usually, if my goal dose is 500 milligrams 3 times a day, I'll have them start with 500 milligrams nightly. Do that for a week, see how they tolerate it. If they do well, add in a morning dose. If they're not doing so well, go back to what they did tolerate, and then maybe make some dietary changes and try again. One of the things I think when people are taking metformin, if they're eating a higher carb diet, some of these GI side effects tend to be worse. So working with a nutrition team in conjunction with the pharmacologic management can be helpful there, because if you lower the glycemic index, some of these GI side effects are also improved. Women with long-term metformin use, you should screen for B12 deficiency. B12 absorption is reduced with long-term use of metformin. So, when I have these endocrine patients that are not trying to get pregnant come in for their annual checkup, we'll check a B12 if they've been on for over a year. Thank you for the comment on extended release. It does help. Some patients on long-term treatment will transition over to the extended release. So thank you for that comment. It's generally considered a weight neutral over a 10-year time period, but I will tell you that talking to patients, it's not, we don't think of it as a weight loss drug, but it does sort of improve their metabolic function. So that if they're putting in the work with diet and exercise changes, some of these lifestyle changes that these studies have shown to be so effective, if you reduce that or at least improve the insulin resistance, they're going to get more bang for their buck with the diet and exercise. So while long-term studies show that it's weight neutral, I think in the short term we've seen people more successfully lose weight when they otherwise make the lifestyle changes. Just taking the pill alone doesn't tend to do it, but in conjunction with other lifestyle management, we find that it does improve some of the weight loss efforts. Now, contraindications, right? You have to worry about lactic acidosis. So the way if someone's severely infected, don't get the metformin right then. If they have cardiopulmonary dysfunction, if they have kidney disease, right? So different creatinine cutoffs, liver disease because of the increased risk for lactic acidosis. If they already have acidosis, if they have alcohol abuse to the point of having liver dysfunction, they're really not good candidates for dysfunction for metformin. So data for metformin and PCOS. I will. Other forms of PCOS, other forms of birth control pills, other forms of hormonal contraception than birth control pills, like a patch. You get a little bit less of the first pass effect through the liver with patches, but you certainly do get so less sex hormone binding globulin effect, but you still get reduction in hyperandrogenism. So a patch is a good option for somebody who either can't tolerate or doesn't want to use a daily pill. Okay, so metformin for PCOS, what does the data show? It should not be considered first line for fertility, and we're going to talk about ovulation induction shortly. With regards to insulin resistance and impaired glucose tolerance, it reduces systemic insulin levels. It increases IGF binding protein 1, which reduces IGF-1 effects, which are some of the less desirable and certainly androgen-producing effects. It reduces production of androgens through steroidogenic enzyme manipulation, reduction in 17-hydroxylase activity. And it also, as I said, can increase sex hormone binding globulin and reduce free androgen levels. So while not everyone with PCOS has impaired glucose tolerance and insulin resistance, those that do can benefit both for the metabolic function as well as the hyperandrogenism. Inositols are another agent that is available for improvements in metabolic dysfunction and PCOS. I think we all learned at least once, and I've probably forgotten a couple times, the function of inositols within cell membranes and second messenger systems. So there's membrane phosphoinositols, and phospholipase C cleaves PIP2 into IP3, which acts as a second messenger system within cells involved in many metabolic functions. There are different forms of inositols present within cells. One is myoinositol, one is D-chiroinositol. They function in glucose metabolism in a number of different ways. Myoinositol is involved with transport of glucose receptors to the cell membrane, as well as conversion to glycogen. D-chiroinositol is involved in insulin signaling pathways and stimulates, I think it's pyruvate dehydrogenase and other metabolizing enzymes. And there's conversion of one to the other by an epimerase in normal function. In women with PCOS, the ratio of myoinositol to D-chiroinositol is altered. Insulin resistance can reduce that epimerase activity, so there's less conversion of the myoinositol to D-chiroinositol, and therefore there can be dysfunction at the level of glucose metabolism as a result of these changes. Because of this, both myoinositol and D-chiroinositol have been proposed as treatments to improve insulin sensitivity in women with PCOS, and the clinical data is fairly limited, but getting more robust. This is a review from 2023, looking at treatment for with myoinositol and D-chiroinositol. They both exert improvements in some of the symptoms. So cycle regularity, acne, various endocrine and metabolic parameters, multiple studies looking at multiple different things, and other markers of insulin resistance. Small studies, nobody showed any improvements in clinical pregnancy rates. There's very limited data on inositols in conjunction with metformin. However, I will say that we do use combination therapy, and sometimes people that are maxed out on metformin that are still not meeting their goals and are still showing signs of hyperinsulinism will have an improvement in some of their lab parameters with addition of inositols. There are multiple different commercially available forms. Myoinositol only is Pregnitude, a combination, and these are not the only ones on the market, but these are the ones that we see patients using commonly. And I'm a big fan of Avasitol, which is a combination of the two. We give 4 grams daily. It's an adjunct. Once somebody gets pregnant, we have them stop it. There's limited data in pregnancy. Some people are reporting it in pregnancy. Just in my clinical experience, once there's a positive pregnancy test, I stop it because there's not as much known. Similar to the way metformin is being used more and more in pregnancy, I think people are becoming more comfortable with it. Right? People in the audience for this talk can probably educate me on that. One of the hot topics in medicine, you watch TV, you see commercials for GLP-1 receptor agonists everywhere. So people are now looking at it, for use in PCOS. The weight loss is pretty remarkable, and so there's not a lot of published data already. But if you look at the clinicaltrials.gov at people looking at it, probably within the next 5 years, there's going to be a lot more data on GLP-1 receptor agonists and PCOS. But the limited data that does exist shows that it's more effective than metformin in reducing BMI. Well, that's not surprising, knowing that metformin is mostly weight neutral, maybe some small increases, and these medications do a great job in losing weight. But if you look at waist circumference, insulin resistance markers in women with PCOS, GLP-1 receptors did a better job than metformin. Headache and nausea are adverse reactions that are commonly seen with these agents. It seems, although this remains to be teased out, that a majority of the improvements are due to weight loss. So if you just sort of look at the bariatric surgery data, where there's a number of these metabolic parameters that get better, it might just be that the weight loss is the reason for it. I think there's going to be more to come with that. There are concerns regarding pregnancy safety. So the current recommendation is to delay pregnancy for 2 months after the use of these. So if somebody has significant weight to lose, it may be worth a course of this to get some significant weight loss prior to pregnancy. But we recommend waiting 2 months before attempting pregnancy. This is one of the first RCTs that I was able to find looking at Saxenda. This was a group in Baton Rouge, John Storment and his group. Small study, 88 participants. They showed it was a 32-week course of Saxenda, 6% reduction in body weight compared to 1.4 in placebo. GI events were much more commonly seen in the treatment group. But they looked at free androgen index, which was improved after 32 weeks on Saxenda, menstrual cycle frequency, so average of 4 menses per year, pre-treatment, and up to 8.5 or 9, I guess 9 menses per year after 32 weeks. So that some improvements, certainly weight reduction, some improvements in menstrual function. So I think we're going to see more and more on this. I'll come back in 5 years and give you an update on what's new with the GLP-1s, but I think we're going to be seeing them a lot more commonly, and there's going to be a lot more data specific to PCOS within the next couple of years. So now we're going to talk about women desiring pregnancy, right? So oligo-ovulation. So one of the sort of classic pictures in the REI world is the Legros PCOS pregnancy and PCOS trial back from 2007. RCT, multi-center, 3 treatment arms, Clomid plus placebo, metformin plus placebo, and Clomid and metformin in combination. And really, very clearly showed that Clomid was superior to metformin for clinical pregnancy rate, 24 compared to 9, live birth rate, 22 compared to 7. Loss rate was even a little bit improved, and multiple pregnancy obviously was higher with ovulation induction compared to metformin. There was a trend towards improvements with metformin and Clomid in combination, but in this study, they weren't able to show it significantly. There have been multiple follow-ups since that study looking at clinical pregnancy rates and live birth rates with combination Clomid plus metformin versus Clomid alone. There have been clear improvements in clinical pregnancy rates, but not live birth rates with the combination. The PCOS2 was also Legros et al. This was 2014, Clomid versus letrozole. Letrozole being off-label use for ovulation induction. Again, double-blinded, multi-center, compared Clomid 50 milligrams versus letrozole 2.5 milligrams. They looked at live birth rate, and then they looked at a number of secondary outcomes, ovulation, pregnancy loss, singleton, congenital anomalies. And long story short, letrozole was superior. Letrozole was associated with a higher live birth rate and ovulation rates among infertile women with PCOS compared to Clomid. I pretty rarely will prescribe Clomid for ovulation induction for a woman with PCOS. I am definitely team letrozole on this. One of the things I think is important to be aware of as general OBGYNs prescribing ovulation induction medications to women with PCOS is that with letrozole, you really need to be sure that they're not pregnant when they take it. If someone takes Clomid while they're pregnant, they're not going to necessarily cause any harm. Reducing estrogen production in early pregnancy, it is potentially concerning with letrozole. So I think documentation of a negative pregnancy test prior to, starting on what is reported as day 3 of a cycle, which may not be day 3 of a cycle, might be implantation bleeding. These are women with irregular cycles. You just have to be careful about prescribing letrozole unmonitored in women with oligo-ovulation with the goal of ovulation induction. But when done carefully, it's more effective than Clomid. There's a number of women who will not respond to Clomid. So, classically, Clomid is first line. So moving to Femara, either skipping Clomid altogether, or in somebody who's Clomid resistant and then going to Femara as second line. Adding metformin may help. Laparoscopic ovarian diathermy, drilling can be helpful. Not something I've seen since fellowship, but is an option. Adding dexamethasone to Clomid, there's some changes at the level of the hypothalamus that may help promote more FSH response to the Clomid compared to no dexamethasone on board at the time of it. So definitely there are some people that won't respond to Clomid that do respond Clomid plus dexamethasone. Going directly to recombinant human FSH is an option. It's a risky option, right? Certainly, the risk of multiple pregnancy. These are women who have obesity and risk for gestational diabetes, and then you're going to compound that with multiple pregnancy. That's a risky endeavor. So my personal practice is to be very very cautious with recombinant human FSH in women with PCOS that don't respond to the oral medications or that fail. This is a pretty nice algorithm. Again, I like algorithms. Human Reproduction Update 2016. They meet criteria for PCOS, but they're ovulating. Let them try a little bit on their own. They're not ovulating. We're going to work them up. We're going to talk about lifestyle. We're going to do our standard evaluation for PCOS. If they ovulate with that, great. But this is now anovulatory infertility. So Clomid or letrozole, again, where do you like to start? I think it's a preference. Clomid is FDA approved for this. Letrozole is off-label use. Clomid can be safely used unmonitored. Letrozole, you just have to be a little bit more careful with confirming that they're not pregnant before they take it. If it works, try it a few cycles. If it doesn't work, now this one says IVF, which more and more is becoming the preferred path and safer with higher success rates and lower risk for multiple gestation. Sometimes people don't want to do IVF. Sometimes insurance won't cover IVF. There is a role for careful, low-dose gonadotropins. Low and slow protocol, the patients get really frustrated because they have to come in over and over and over again for ultrasound and blood work because they'll go from nothing to four or five follicles growing. There's a high risk for cycle cancellation in these patients, so you just have to be really careful with it. If we're doing IVF, these are women who have just about every risk factor for ovarian hyperstimulation syndrome. They're high responders. A GnRH antagonist protocol allows us to use a GnRH agonist trigger, so Lupron trigger. We also are 100% freeze all practice here at RMA. Some practices still use fresh embryo transfers, but one of the best ways to reduce the risk for ovarian hyperstimulation syndrome is to do a cryo-all cycle. They may get the early, OHSS, there's sort of two waves. There's the early wave around the time of retrieval, but the more severe wave can come with a positive pregnancy test after transfer. And so if you do a fresh transfer and you get pregnant and the pregnancy hormone restimulates the ovaries and redrives the process of VEGF and multiple other, sort of inflammatory mediators from the ovary, these patients can get really sick. So Lupron trigger, cryo-all, elective single embryo transfer, excellent success rates, 1 to 2% risk of multiple pregnancy, even lower than, letrozole and Clomid, where we're talking, 8% risk of multiples. I've seen one set of triplets in my career from letrozole. So it does happen, but it's extremely rare. Again, the earlier M&M presentation of single embryo transfer and why that's a good idea. It's a great treatment option. I think, if ovulation induction with oral medication is unsuccessful and the patient is able to progress to IVF next, it's a great option. So now we're going to talk a little bit. I realize we got 10 minutes to go. Am I supposed to leave time for questions? After, reproductive lifetime, it doesn't go away, right? The metabolic dysfunction is there. Another nice review article on sort of PCOS through the life journey of a woman. I didn't go into some of the, interesting data on sort of in utero exposures and risk of development of PCOS, but there's a lot of good data that sort of low resource environments intrauterine, like IUGR or SGA, may program some of the PCOS phenotype. Young prepubertal girls, you might start to think about it with early menarche, early pubarche, obesity. And, again, the chicken and the egg, is it the obesity that's promoting some of these things, or are they programmed for that? It's hard to say. Certainly in the, young adult and adult reproductive age life, everything that we just talked about in this talk, all these different issues are coming up, and depending on what they're presenting to you with, that's what we're going to try to manage. After the reproductive years, though, there's a big risk for type 2 diabetes, cardiovascular dysfunction, dyslipidemia, endometrial cancer, right? We talked about chronic anovulation. So it doesn't go away after menopause. So it's something that needs to just be followed lifelong. So in pregnancy specifically, there's a 2 to 3-fold increase in gestational diabetes. Some studies show that women that and it may just be limited to hyperandrogenic women. There may be an increased risk of preeclampsia. Certainly, these things are compounded with multiple pregnancies. So again, that's why I'm a big fan of oral medication, ovulation induction, 8% risk of twins. It's not zero, but it's relatively low compared to 25+% with injectable gonadotropins. And then if that's not successful, IVF with a single embryo transfer is a great way to reduce the risk for multiples. During perimenopause and the menopausal transition, women sort of do their own ovarian wedge resection with the natural progression of ovarian aging. So as those multiple follicles reduce, we often find people saying that their cycles become more regular in their 40s. So as their high AMH comes down to a more normal level, their cycles will often regulate a little bit. Menopause might be delayed by up to 2 years. They tend to present with more hirsutism complaints and less vasomotor symptoms. And basically, it's a transition from metabolic symptoms starting to outweigh the gynecologic symptoms after menopause. Basically, multidisciplinary approach. OBGYN are very involved in the reproductive years, a little bit less so, but not completely. We're following women through the life cycle, but a lot of shift to the metabolic dysfunction as opposed to some of the hormonal and menstrual dysfunction. So there are lifelong risks: obesity, impaired glucose tolerance, dyslipidemia. There's an increased risk for coronary artery disease, metabolic syndrome, sleep apnea. The NASH data is pretty impressive. I think 40% to 50%, and that doesn't go away with menopause. Endometrial cancer. There's a huge, even in the reproductive years, but also after the reproductive years, anxiety and depression are much more commonly seen in women with PCOS. Disordered eating as a result of this. So there are a number of things to really key in on. It's not all ovulation and hirsutism. Good surveillance plan over time, just at least every couple of years, screening for impaired glucose tolerance and metabolic dysfunction. Lifestyle modification remains first line, but some of these things might need to be managed pharmacologically. Summary. So I got 6 minutes to go. So it's not one size fits all. Really, the goals of the patient, her presenting complaints, which are many. Lifestyle modification is sort of step one for every complaint. Suppression of androgens, birth control pill is great in someone who's not trying to conceive. For ovulation induction, oral medications first. I'm team letrozole. PCOS2 was a good study that really showed it is superior to Clomid, but you just have to monitor carefully and make sure you're not giving it to somebody who's early pregnant. Second line, for me, IVF, if we can do it. If we can't do it, very careful recombinant human FSH injections. Treatment for impaired glucose tolerance, we have metformin, we have inositols. There's going to be more data coming out on inositols because there's a number of ongoing studies. And just remember, this is a lifelong disorder. It doesn't go away at the time of menopause. So with that, I will finish. I will take any questions. I know there's been a couple of questions coming in as I went along that I tried to answer quickly, but I think I missed a couple. So yeah, I encourage any questions.
Dr. Doherty, thank you so much for that excellent talk. Yeah, why don't we look at Dr. Bayat's questions in the chat first? Her first question, can you read it? Otherwise, I'll read it to you.
Let me see if I can find it. Nice review article. Hold on.
Are other forms of combined oral contraceptives like patch and ring as effective as the OCPs?
Yeah, so that I saw that one come by. I think some of the sex hormone binding globulin stimulation is via the first pass through the GI tract. So I think you don't get as much of that, but certainly for suppression of LH and suppression of ovarian androgen production, they're going to be equivalent. So I think, maybe not as effective for the free androgen, but certainly cycle regularity, endometrial protection, that's all going to be there.
What about a woman who's getting regular cycles, doesn't have hyperandrogenism, but on ultrasound, there's an incidental finding of polycystic ovaries?
So they have regular cycles and no hyperandrogenism.
Right.
So they wouldn't meet Rotterdam criteria. They just have polycystic appearing ovaries. I I think it's someone that I would I sort of think of PCOS as a spectrum, right? So are they mildly on the spectrum, or they just for whatever reason have a higher ovarian reserve? It's someone it would kind of raise a yellow flag that this is someone I keep an eye on their metabolic function over time. But if they're having regular menses and just have a high follicle count, I wouldn't necessarily manage them any differently. Now, if they were infertile and coming for fertility treatment, I would still likely start with superovulation, oral medication, not injectables, and treat them as carefully with FSH and IVF as I would anyone that meets criteria for PCOS. But I certainly wouldn't treat them with metformin or anything to lower androgens.
I think that Dr. Bayat's third question you already answered, so we can go on to Sue, who has her hand raised. Sue? Sue, you're muted if you're trying to talk. Sue typed into the chat, can you touch on how to distinguish between PCO versus MFO using the ultrasound appearance only? I think you just answered that one, right?
I believe so. Yeah. So there are strict criteria. I think it's greater than there's ovarian volume criteria and ovarian follicle number criteria on one or both ovaries that will meet the diagnostic criteria for polycystic ovarian morphology. So I'm not there's that distinct criteria, and then I guess multifollicular. I'm not familiar with MFO, but just I think multifollicular ovary, like it's also, I guess, also the distribution within the ovary. So I think sort of the classic string of pearls peripheral distribution of follicles. You think more commonly with polycystic ovarian morphology. Maybe that's the question. So more peripheral dispersion, bright, abundant stroma. That's that stroma that's pumping out all the androgens. Centrally with the peripheral sort of string of pearls or small peripherally distributed follicles.
Well, we only have 1 minute left. I see that Dr. Sauer has turned his camera on. Dr. Sauer, did you want to say something?
That usually means I have to say something, right? Great review, Leo. I appreciate it. Just to comment, first of all, up to your comment, I agree with you. I think a lot of PCOS, especially in younger women and teens, is way overused, and they go through a decade or so thinking they have PCOS when in fact they just have, megalocystic looking ovaries that tend to normalize later and behave perfectly normally. They have no insulin resistance, they have no weight issues, and on and on. So I think we have to be very careful. And to Dr. Doherty's points, making a correct diagnosis using criteria that relates largely to insulin, really, and the things that happen downstream from that. I'm glad you brought up the issues with Ozempic and these other new agents, because I think that's going to be a big issue. I think people are already using them widely off-label, and PCO patients are the ones that are coming in for that. They don't necessarily meet criteria as diabetics, which is how it's marketed, right?
Yeah.
But it's commonly being used. I know we're out of time, but I just want to know one quick comment because I think it's a big part of PCOS is the mental health issues. They definitely have a lot of anxiety and depression, not just in their teens, but throughout life, usually from the time of diagnosis. And I find that typically programs aren't really equipped or don't really address mental health. I mean, what's your opinion about that?
Yeah, I think in general, it's just something that if you don't ask and scream for, you're going to miss. The clinical, I mean, the research data shows, I mean, extremely high incidence. I think it's real, vigilance and having resources available. I mean, I think we're lucky in our practice. We have a mental health team that we can screen them, and if do some counseling internally, or at least provide them with resources outside of the practice. It's kind of one of our lucky things about being big is that we have a mental health team. We have this. But I think the thing to just be wary of it is if you don't ask for it, you could miss it, and it's super common. I agree.
All right. Well, we're just about out of time. So Dr. Doherty, thank you so much.
You're welcome. Everybody
Thank
have
you.
a great
Thank
day.
you, everybody. And thank you, residents, for all that you do.
Yes, thank you, residents.
All right. So we'll end it there. I hope everyone, especially the residents, have a safe and productive day.
Bye.